In this orthokeratology case, we have a patient who's got about a diopter of corneal sill, a little bit less than that in the refraction, but the post-treatment refraction shows a little bit more than a diopter of cylinder. So we want to address with the voltricity that's being induced by lens treatment. We've got a lot of blue in the periphery of the post-treatment topography, so we're getting good applanation all the way around. I think in this case, if we look at the numbers, we're probably just getting a little bit more than we need in the horizontal meridian. We're down in the low 30s in terms of dioptric power, maybe even in the high 20s over on the temporal side. So what I would do in this case is reduce the sagittal depth, relieve some of the compression we have in the vertical meridian, but maintain what we have in the horizontal, and that should give us a little bit less induced astigmatism. So we'll do this in 50% mode, and right now we're at a sagittal height of 659 microns at this point. So I'm going to lift it by 15 microns, so our new target will be 645. We're in freeform mode, actually freeform mode down here. So we'll do the same thing over here. We're starting at 668, so our new target will be 653. In the superior and inferior quadrants, we should still have good applanation like before. It will look like we're going to get a lot of edge clearance in the horizontal meridian. You may see some misting of fluorescein underneath the lens, but I don't think it will be as dramatic as what the tear graph indicates. If we create a difference map between the most recent and the baseline topography, you'll see that we're getting a peak flattening of almost 5 diopters right at the center, and that slowly decreases even within the treatment zone. But I think with that amount of shape change and a minus 450 or so refraction, your total power is probably okay. I don't think we necessarily have to increase that, even though the post-treatment refraction doesn't come out to a plano UDS, it does come out to a slightly mild minus UDS. I would just make the changes in the periphery to help address the induced cylinder. For the left eye, we're getting a similar post-treatment refraction. If we look at the post-treatment topography, we're getting some movement of the lens. Not very good seal off here. We can see where the lens is decentering nasally a little bit. And in this case, I believe we're using a G-sim lens. So here's the lens for the left eye. It's in G-sim, and we have a little bit of clearance that shows in the horizontal meridian, in the periphery, and then some digging in of the edge superiorly, and then touching down inferiorly right at the back edge of the reverse curve. If we look at the height map, or the spherical offset map for this left eye, there's enough asymmetry inferior to superior where I think going with a freeform lens does make sense. So what I would do for the left eye is go ahead and create a new lens in freeform. You can use the same parameters otherwise, and then after that go ahead and build in your differential of about 15 microns. Again, there is a fair amount of blue out here in the periphery, and although it's kind of difficult to predict exactly how the freeform pattern will look as opposed to this G-sim, I would still make the changes just in the horizontal meridian, because it does seem like it's not too loose vertically. So just lift the lens horizontally 15 microns on both the temporal and nasal side, and that should help address the patient's induced cylinder. So those are my thoughts. Best of luck on your case.